Sashidhar. I'm working in Ayush Hospitals, Vijayawada. Today, I have given a topic on the latest update in hypertension. As you all know, that nearly 63% of total deaths in India are due to non-communicable diseases, of which 20%, 27% are attributed to CVD, which affects 45% people in the age of 40 to 69. Raised blood pressure is among the most important risk factors for CVDs. Moreover, it remains poorly controlled due to lower awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has also gone up to 30 years to 38% in men and 32% in women, from 29% and 28% respectively. Despite that, nearly half of the people, are 51% of the men and 41% of women with hypertension, were unaware of the condition. Additionally, over 62% of the men and more than 53% of women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than one in 5 men and 1 in 4 women with hypertension. This is according to WHO Lancet 2021 and 398 and 957 to 80. International Society of Hypertension (ISH) has released the ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigms attempts to address the issues that in resource-poor settings. Optimal care refers to evidence-based standard of care, and whereas essential standards refer to minimum standards of care to allow specification of essential standards of care for lowering resource settings. Both the AHA and ACC has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low ASCVD risk. Among low-risk adults, no ASCVD or 10-year CVD risk less than 10%, stage 1 hypertension 130 to 139 systolic, and diastolic is 80 to 89. Management starts with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting a pharmacological therapy. Acute respiratory distress syndrome (ARDS) is a potentially fatal condition involving lung damage, and experts often associate it with severe COVID-19. A recent study, which appears in the Journal of American College of Cardiology, reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19-induced ARDS. This lowering systolic blood pressure targets down to the 110 to less than 130 mmHg range substantially reduce CV adverse events in the step randomized trial, affirming the sprint findings for an older Chinese population. Among some 8,500 patients ages 60 to 80 in China, the intensive target trimmed 26% of the composite CV risk. Findings from now a second major trial supporting a lower target could unite the guidelines, which even among US professional societies range from thresholds of 130 to 150 mmHg of blood pressure. With regard to prognostic value of ambulatory blood pressure monitoring at night time, blood pressure, the 2018 European Guidelines on the Management of Arterial Hypertension recommend that the diagnosis of hypertension should only be dependent on office BP measurements only, but also an out-of-office measurements such as ABPM or home blood pressure monitoring, 24 hours that is, and nighttime BP measurements were associated with greater risk of mortality and a composite of CV outcome. Thus, they may be considered as the most relevant measurement for estimating CV risk. For every 20 to 10 mmHg increment of blood pressure measured at night, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal blood pressure control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs, considering the high non-adherence treatment. The importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed combination of ACE1 or ARB plus ECB or diuretics. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of a known carcinogen, namely N-nitrosodimethylamine, which can be found in candisterone or irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO International Agency for Research of Cancer to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminated valsartan from Chijan and Wuhan, a manufacturing site where the highest levels of contaminants were found every day for 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancers causes cases in 1 lakh patients if they have taken the highest daily dose for 4 years. Valsartan recall accompanied by the significant decrease in the rate of emergency department visits of around 6%. The HIGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints, including death. The HIGEA chronotherapy trial tested whether nighttime therapy, in comparison to usual upon awakening hypertension therapy, exerts a favorable CV risk reduction. The largest study included a total of 19,084 hypertensive patients during an average follow-up of 6.3 years. 1,752 participants experienced the primary CV outcome. An ambulatory blood pressure measurement was performed for 48 hours to collect data on how BP differing during sleep. The RR reduction for CV events was significantly improved for nighttime treatment when compared with awakening treatment. Thank you, everyone.